morning, dear students. Today's lecture consists of two parts. The first part is Diabetes mellitus, its etiology, pathogenesis, classification, and diagnostic criteria. The second part will be about thyroid gland disorders, thyroid gland diseases, Graves' disease or toxic goiter, and hyperthyroidism or decreased function of thyroid gland. Clinical picture and diagnostic criteria, our first topic. So diabetes mellitus is endocrine and metabolic disease which develops due to absolute or relative insulin insufficiency and characterized by chronic hyperglycemia, changes of different systems and organs of the patient. This is the definition of diabetes mellitus. So the clinical syndrome known as diabetes mellitus comprises a wide variety of symptoms, physical findings and laboratory abnormalities in which multiple etiologic factors are involved. The pathophysiology is partially understood and treatment is unsatisfactory. The hallmark of diabetes mellitus is hyperglycemia. So some words about insulin. Insulin, the most important biological stimulator of insulin secretion, is glucose. And insulin is an anabolic hormone, promotes the synthesis of carbohydrates, proteins, lipids, and nucleic acids. The most important target organs for insulin action are liver, muscles, and adipocytes. The brain, nervous system, retina, lens, and blood cells are unresponsive to insulin, and it has no direct influence on kidneys. The effects of insulin on carbohydrate metabolism: stimulation of glucose transport across muscles and adipose cell membranes. Insulin plays a role in regulation of hepatic glycogen synthesis and inhibition of glucose formation from glyconeogenesis and from amino acid precursors glyconeogenesis, and the result of these actions is a reduction in blood glucose concentration. The influence on protein metabolism, the transfer of amino acids across plasma membranes, stimulation of protein synthesis, and inhibition of proteolysis. And insulin influence on lipid metabolism, incorporation of fatty acids from circulating triglyceride into adipose triglyceride, stimulation of lipid synthesis, and inhibition of lipolysis. Nucleic acids metabolism. Insulin stimulates nucleic acid synthesis by stimulating the formation of adenosine triphosphate, DNA and RNF, and insulin has other effects such as stimulation of the intracellular flow of potassium, phosphate and magnesium in the heart, and inhibition of inotropic and chronotropic action unrelated to hypoglycemia. Insulin insufficiency may be of two types, absolute and relative. Absolute due to genetic disorders, autoimmune damaging of beta cells of pancreas, damaging by viruses such as mumps or Coxsackie, toxic influence on beta cells, and diseases of pancreatic gland. Relative insulin insufficiency may be due to disorders of insulin transport or disorders of tissue sensitivity, disorders of receptors, tissue receptors, so-called tissue insensitivity towards insulin. Classification of diabetes mellitus. Diabetes mellitus is classified into four main groups. Type 1 of diabetes mellitus is characterized by absolute insulin insufficiency due to destruction of beta cells. It may be autoimmune and idiopathic when we don't know etiology. The next, type 2 of diabetes mellitus. This type is characterized by relative insulin insufficiency. The third group is called other specific types of diabetes mellitus. The causes of these types of diabetes mellitus are genetic defects of beta cells function, genetic defects of insulin action, some pancreatic diseases such as chronic pancreatitis or trauma, some other endocrine diseases such as acromegaly or thyrotoxicosis, drug exposures, infections. And the fourth group of diabetes mellitus is gestational diabetes in pregnant female. Today we are going to talk about type 1 and type 2 of diabetes mellitus, so the most spread and most common types of diabetes mellitus. So diabetes mellitus has three stages of development. The first is prediabetes. It is equal to presence of risk factors or predisposed factors of diabetes mellitus. The next stage, impaired glucose tolerance or latent diabetes mellitus. And the third, clinical manifestation of diabetes mellitus. Prediabetes or risk factors or predisposed factors of diabetes mellitus are the most important of them: obesity. The next, positive family history of diabetes mellitus. Persons which were born with weight more than 4 kilograms, and women who had children with weight more than 4 kilograms. The next, persons with atherosclerosis and hypertension, autoimmune diseases, such infections such as rubella, Coxsackie virus, infectious hepatitis, cytomegalovirus, and infection mononucleosis. And the last most important risk factor is endocrine disorders, other endocrine disorders, such as acromegaly, for example. Diabetes mellitus is also classified in degrees of severity. Degrees of severity are assessed by fast serum glucose level, glucosuria level, compensation, which may be achieved or not achieved, and chronic and acute complications of diabetes mellitus. According to this parameter, diabetes mellitus is divided into mild, moderate, and severe. So this assessment tool is presented on the screen, and by these parameters we may assess the degree of severity of diabetes mellitus. Diabetes mellitus is also classified by stages of compensation. There are two stages, compensative stage and decompensative stage. Compensative stage. Criteria of compensative stage are: patient hasn't new complaints, fast serum glucose level is normal, glucose in urine is absent, glucose level fluctuation is under 4.4, from 4.4 to 5.5 millimole per liter during the day, and the most important parameter nowadays is glycated hemoglobin. So glycated hemoglobin is from 6.0 to 7.0 for the first type of diabetes mellitus, and the level of glycated hemoglobin from 6.0 to 6.5 for the second type of diabetes mellitus. And the last criteria of compensative stage: absence of acute complications of diabetes mellitus. Comatose and precomatose status must be absent. So these are criteria of compensative stage. Decompensative stage criteria: the first, postprandial glycemia is more than 9.0 millimole per liter, glycated hemoglobin is higher than 7.5 for the first type of diabetes mellitus, and more than 7.0 for the second type of diabetes mellitus. And the most important, comatose and precomatose status may be present. So acute complications of diabetes mellitus are present in decompensative stage of diabetes mellitus. Duration of diabetes mellitus may be stable and labile. Stable means glucose level fluctuation is under from 4.4 to 5.5 millimole per liter during the day, and comatose or precomatose status are absent. And labile is when glucose level fluctuation is more than normal during the day, and comatose and precomatose status may be present. Now we will focus on type 1 of diabetes mellitus, or insulin dependent diabetes mellitus. It's the synonym. This type of diabetes mellitus is characterized by pancreatic islet beta cell destruction and absolute insulinopenia. These individuals are ketosis prone under basal conditions. Very important idea: the onset of this disease is generally in youth, but it can occur at any age, and patients have dependence on daily insulin administration for survival. Type 2 or non-insulin dependent diabetes mellitus is most common form of diabetes accounting for 90% of the diabetic population. And the most important risk factors and etiological factors of this type, second type of diabetes mellitus, are genetic factors, obesity, diet, physical activity, and stress. Among the most important factors are environmental factors, which play a role in the development of this disease. So this table let us compare type 1 and type 2 of diabetes mellitus. So type 1, the age of onset is young age, under 35 years. Beginning of the disease is acute. Duration is labile. Ketosis and ketoacidosis often develops. Body weight decreased or normal. As for type 2 of diabetes mellitus, age of onset is old or middle. Beginning of the disease is gradual. Duration of the disease is stable. Ketosis and ketoacidosis rarely develops. And body weight for the second type of diabetes mellitus, obesity is characteristic. So obesity in 80-90% of patients. As for treatment, in case of type 1 of diabetes mellitus, we need insulin and diet. Degrees of severity for type 1 are characteristic, severe and middle. Seasons of disease beginning for the type 1, frequently autumn and winter period. Connection with HbA system. In case of type 1, present. And once more, very important characteristic, level of insulin and C-peptide. In case of type 1, level of insulin and C-peptide decreased or absent, because this type is characterized by absolute insulinemia, absence of insulin. Type 2. As for treatment for type 2, we use diet, drugs, and insulin. Degrees of severity may be mild, middle, and severe. Season of disease beginning for type 2 absent. Connection with HbA system absent. And level of insulin and C-peptide frequently normal, because this type 2, is characterized by relative insulin decreased sensitivity of tissues towards insulin. That is why insulin level may be even normal in these patients, but peripheral tissues are insensitive to towards the insulin. The next characteristic for type 1 is characteristic presence of antibodies to beta cells. As for late complications, type 1 is characterized by presence of microangiopathies. Mortality in case of type 1 diabetes mellitus less than 10%, and spreading is from 10 to 20%. As for type 2, antibodies for beta cells are absent. Late complications for the type 2 are characteristic macroangiopathies. Mortality is very high, more than 20%, and spreading is also very high. So type 2 is 80 or 90% of all diabetes patients. So pathophysiology of diabetes mellitus. Lack of insulin leads to hyperglycemia, high level of glucose, serum glucose, glucosuria. Glucosuria leads to polyuria and dehydration of patients. This leads to defective polymorphonuclear function and infections, and hyperosmolality. So this is influence on carbohydrate metabolism. Also, insulin lack leads to increased proteolysis. In case of the first type of diabetes mellitus, it leads to weight loss, muscle wasting, and polyphagia, very important symptom of diabetes mellitus. Insulin lack also leads to lipolysis and free fatty acids release, so it will lead to ketosis and acidosis, to the development of acute complications of diabetes mellitus. Clinical presentation. The classic manifestation of the first type of diabetes mellitus include polyuria, when the level of blood glucose is more than 9 millimole per liter. Glucosuria arises. The next symptom, very important symptom, polydipsia. As more water is exerted, the body requires more water intake. The next symptom, polyphagia, as a result of lack of energy, loss of weight, fatigue and weakness, probably occur as a result of decreased glucose utilization and electrolyte abnormalities. Acidosis develops due to increased lipolysis, which cause the release of free fatty acids, which are metabolized to ketones by the liver. Symptoms of the second type of diabetes mellitus include polyuria, polydipsia, and polyphagia, but they are not so prominent as in case of diabetes mellitus of the first type. Now we will talk about long-term or chronic complications of diabetes mellitus. They are divided into two main groups, diabetic angiopathy and diabetic neuropathy. Diabetic angiopathy may be microangiopathy. The damage of the vessels of kidneys is called nephropathy. Damage of the vessels and capillaries of retina, retinopathy, and may be angiopathy of lower extremities. Macroangiopathy includes damage of large and medium vessels such as heart vessels In this case, patients will develop ischemic heart disease, brain vessels, or maybe angiopathy of lower extremities. Diabetic neuropathy includes central neuropathy or encephalopathy and peripheral neuropathy and visceral. So the long-term degenerative changes in blood vessels of the heart, kidneys, nervous system, and the eyes are responsible for the most of the morbidity and mortality of diabetes mellitus. That is why we must know about these long-term complications. So we will start from cardiovascular system. Diabetic autonomic cardiomyopathy may develop, and this damage is characterized by orthostatic hypotension, which is characterized by dizziness, faintness, syncope upon assumption of the upright posture, and is caused by failure of peripheral arterial constriction. So also the symptom may be tachycardia, but it does not occur in response to hypotension because of sympathetic involvement. Cardiovascular disorders of diabetes mellitus includes dysmetabolic cardiomyopathy also. The clinical presentation of dysmetabolic cardiomyopathy includes rhythm disturbance and ischemic heart disease. Ischemic heart disease has some peculiarities in patients with diabetes mellitus. So cardiovascular changes tend to occur earlier in patients with diabetes mellitus when compared with individuals of the same age. Frequency of myocardial infarction and mortality is higher in diabetics than that in non-diabetics of the same age. The prognosis is even worse if ketoacidosis and other complications of diabetes mellitus are present. And diabetic patients have more complications of myocardial infarction, such as arrhythmias or cardiogenic shock, than non-diabetic ones. And the most important idea that the patients with diabetes mellitus may have atypical forms without pain. This type of myocardial infarction without pain is very characteristic for diabetic patients. The next target organ of diabetes mellitus is kidneys and urinary tract. So for diabetes mellitus is very characteristic inflammation process, such as pyelonephritis, cystitis, pielitis in diabetic patients. Diabetic cystopathy or neurogenic vessel dysfunction, which is characterized by enlargement of the volume of urinary bladder, and insidious onset and progression of bladder paralysis with urinary retention, decreasing of quantity of urinations. The next very important clinical presentation is diabetic nephropathy, the damage of kidneys. Diabetic nephropathy has stages. The first stage is hyperfunction of kidneys. This stage is characterized by increased renal blood circulation and increased glomerular filtration rate, more than 1040 milliliter per minute, by hypertrophy of kidneys and normal albuminuria, less than 30 milligram per day. The second stage of diabetic nephropathy is a stage of initial changes of kidney structure. This stage is characterized by mesangial changes due to accumulation of immunoglobulins G and M, complement, and other non-immunological proteins. This stage is also characterized by high glomerular filtration rate and normal albuminuria. The next, third stage, initial nephropathy, is characterized by microalbuminuria from 30 to 300 milligrams per day, high or normal glomerular filtration rate, and periods of blood hypertension. The fourth stage, nephropathy or nephrotic stage. This stage is characterized by persistent proteinuria, more than 500 milligram per day, normal or decreased glomerular filtration rate, and persistent high blood pressure. And the last stage is the stage of chronic renal failure and uremia. This stage is characterized by extremely decreased glomerular filtration rate, high blood pressure, increased serum creatinine, and signs of uremia and endogenic intoxication. And once more, the renal failure and diabetic nephropathy is the main cause of mortality of patients with diabetes mellitus. That is why you must remember about this long-term complication of diabetes mellitus. The next target organ are eyes. So the damage of eyes in case of diabetes mellitus is characterized by presence of keratitis, retinitis, cataract, and glaucoma. But the most important is diabetic retinopathy, the damage of vessels of capillaries of retina. So evidence of retinopathy rarely present at diagnosis in type 1 of diabetes mellitus and is present in up to 20% of type 2 of diabetes mellitus. But about 85% of all diabetics eventually develop some degree of retinopathy. The initial retinal changes seen on the ophthalmoscopy does not significantly alter vision, but it can lead to processes that cause blindness. Diabetic retinopathy is classified according to the changes seen at background during ophthalmoscopic examination, and it has three stages. The first stage, background retinopathy. The second stage, maculopathy or pre-proliferative retinopathy. And the third stage, proliferative retinopathy. The first stage, background retinopathy, is usually the earliest sign and consists of retinal microaneurysms, hard and soft exudates. Like on this slide, exudates. The second stage, maculopathy or pre-proliferative retinopathy, is characterized by macular edema and hemorrhages. like on this example, hemorrhages. And the third stage, the hallmark of proliferative retinopathy is neovascularization. It means growth of new vessels in areas of hyperperfusion. Adhesion of the vessels to the vitreous leads to retinal detachment, vitreous hemorrhages, and others, and the prognosis is extremely poor. 5 years after recognition of this complication, 50% of the patients are blind. A very serious complication of diabetes mellitus. The next long-term complication, diabetic angiopathy of lower extremities. It means atherosclerosis of large vessels. This atherosclerosis leads to intermittent claudication, cold extremities, or other symptoms, which can be also found while arterioles and capillaries are affected. Macroangiopathy, so combination of macro and microangiopathy. Classification of lower extremities angiopathy includes 3 stages. Non-clinic stage, changes could be found only during instrumental examination. The next stage, functional stage, is characterized by cold extremities, numbness, tingling, pain during physical examination. And organic stage is characterized by trophic changes such as dry skin, hypo or atrophy of muscles, ulcers, and gangrene. The next long-term complication is diabetic foot. Appearance of diabetic foot is caused by combination of vascular insufficiency, neuropathy, and infection. Diabetic foot is divided on ischemic, neuropathy, and mixed type of diabetic foot. So this table presents the comparison of ischemic and neuropathic types of diabetic foot. The temperature of the skin in case of ischemic type is decreased, color of the skin is paler or cyanotic, pulsation of peripheral vessels in case of ischemic diabetic foot is decreased or absent, edema is absent, sensibility partially decreased or normal, ulcers may be present and they are peripheral, and gangrene may be present and it is dry. And this is the picture which presents the ischemic type of diabetic foot. For neuropathic type of diabetic foot is characteristic normal temperature of the skin, normal or pink color of the skin, pulsation of peripheral vessels is normal, edema may present, sensibility is decreased or absent, and ulcers may appear under the pressure. Gangrene is also characteristic, but it is moist. So, how to make a diagnosis of diabetes mellitus? Diabetes mellitus diagnosis include clinical manifestation of the syndrome of hyperglycemia and presence of long-term complications. And of course, we must have laboratory findings. The most important are fasting serum glucose, more than 6.1 millimole per liter or more than 120 milligram per deciliter on 2 or more separate days. The next, positive glucose tolerance test. We have discussed this test the previous semester. you may revise your knowledge about glucose tolerance test. The next, we may use glycated hemoglobin or glycohemoglobin if its level more than 6.5%. It means that patient has diabetes mellitus. The next parameter, islet cell antibody levels, which will be positive in patients with the first type of diabetes mellitus. The next, we may use C-peptide level or insulin level. C-peptide level and insulin level will be decreased or even absent in case of diabetes mellitus of the first type, and it will be normal in case of diabetes mellitus of the second type. Next, for estimation of compensation of diabetes mellitus, we may use glucose level in urine, acetone and ketone bodies in urine, and we must have the levels of lipids, cholesterol, triglyceride levels for estimating of macroangiopathy and microangiopathy complications of diabetes mellitus. And we use instrumental methods to estimate the complications of diabetes mellitus. For example, if the patient has ischemic heart disease, we may use ECG or heart ultrasound. If patient has nephropathy, we will use ultrasound of abdomen, of kidneys. We will use glomerular filtration rate calculation and detection of creatinine and urea, and so on. This is the rules and rating of glucose tolerant test. Once again, we have talked about this test the previous semester. So if patient has diabetes mellitus, it means that 2 hours after glucose loading, the level of glucose will be more than 11.1. This is the criteria of diabetes mellitus. Acute complications of diabetes mellitus. Acute complications include diabetic ketoacidosis and hyperglycemic syndrome and hypoglycemia. So for the first, about diabetic ketoacidosis and hyperglycemic syndrome. These are two acute complications of diabetes that can result in increased morbidity and mortality if not sufficiently and effectively treated. These two most common life-threatening complications of diabetes mellitus, and there are important differences in their pathogenesis, but the basic underlying mechanisms for both disorders is a reduction in net effective concentration in circulating insulin, coupled with a concomitant elevation of contra-regulatory hormones such as glucagon, catecholamines, corticosterol, and growth hormone. And the combination of insulin deficiency and increased concentration of contra-regulatory hormones causes the activation of hormone-sensitive lipase in adipose tissue. The increased activity of tissue lipase causes breakdown of triglyceride into glycerol and free fatty acids. While glycerol becomes an important substrate for gluconeogenesis in the liver, the massive release of free fatty acids assumes pathophysiological predominance, as they are the hepatic precursors of the keta acids. And that is why a patient will have acidosis and ketoacidosis. So the main causes of these acute complications are underlying or concomitant infection, missed insulin treatments, newly diagnosed and previously unknown diabetes, and some other causes. But the most important and the most widespread are infections, different type of infections. For example, pneumonia or pyelonephritis. These infections may lead to decompensation of diabetes mellitus and development of hyperglycemic ketoacidosis. The symptoms of ketoacidosis: headache, sleepiness, confusion, loss of consciousness, and even coma. Maybe weakness, diarrhea, nausea and vomiting, arrhythmia and tachycardia, and dyspnoea or shortness of breath, and coughing. So these are the most important symptoms of ketoacidosis. There are three degrees of severity of ketoacidosis: mild, moderate, and severe. For diagnosing of ketoacidosis and its degree of severity, we use plasma glucose level, arterial pH, serum bicarbonate level, urine ketone level, serum ketone level, effective serum osmolality, anion gap, and alteration in sensorium or mental adaptation. So the criteria of ketoacidosis and its degrees of severity are presented on this slide in lecture. Treatment of diabetic ketoacidosis includes replace fluid and electrolytes, intravenous insulin therapy, monitoring of complications, treatment of causes, for example, infection, and prevention of recurrence. The next complication is acute complication is hypoglycemic coma. This is a coma due to abnormally low plasma glucose level that leads to symptoms of sympathetic nervous system stimulation and of central nervous system dysfunction. Causes of this coma: this in hypoglycemia occurs most commonly as a result of treating patients with diabetes mellitus, for example, overdosage of insulin or other hypoglycemic medications, alcohol, more rarely salicylates, beta blockers, and diet lacks of carbohydrates in diabetes mellitus patients. The symptoms of hypoglycemia when blood glucose less than 4.0. So these patients may have palpitations, they are nervousing, sweaty, hungry, may feel hunger, weakness, vision changes, high irritability, difficult speaking, headache, personality changes, and coma. So loss of consciousness. Principles of treatment. Priority in treating hypoglycemia to maintain plasma glucose greater than 50 mg deciliter, either snacks or intravenous dextrose. The second priority is to address the underlying cause, removal or adjustment of the offending drug, appropriate hormone replacement for patients with deficiency, resection of the tumor in insulinoma, and so on. And patients with antibodies against the insulin receptor can be treated with high dose of glucocorticosteroids to prevent hypoglycemia. So that's all about diabetes mellitus. The next topic for today, Graves' disease. Graves' disease or Bazedov's disease or diffuse toxic goiter. These are all the synonyms. The definition. Diffuse toxic goiter is the disease of the thyroid gland characterized by hyperthyroidism and one or more of the following: goiter, exophthalmos, and pretibial myxedema. Graves' disease is the most common cause of hyperthyroidism, is an autoimmune disease, and has a chronic course with remissions and relapses. Etiology and pathogenesis. The etiology of Graves' disease is an antibody against the thyroid stimulating hormone receptor, which results in continuous stimulation of the gland to synthesize and secrete excess quantities of thyrotoxin and triiodthyronin. The extrathyroidal manifestations of Graves' disease, ophthalmopathy and dermopathy, are due to immunologically mediated activation of fibroblasts and in the extraocular muscles and skin, with accumulation of glycosaminoglycans, leading to trapping of water and edema. Psychic trauma infections such as tonsillitis, rheumatic fever, dysfunction of other endocrine glands, for example pituitary gland, are important for the development of this disease. Familial factors are also important. So toxic goiter can often be found in close relatives. Clinical picture, clinical presentation. The disease most commonly occurs in women between the ages of 30 and 50. The incidence in men is 5-10 times lower. The clinical picture includes syndrome of hyperthyroidism and one of the following symptoms: goiter, ophthalmopathy, and pretibial myxedema. The signs of ophthalmopathy and dermopathy are specific for Graves' disease. Hyperthyroidism syndrome. Most common complaints are increased psychic excitability, non-motivated anxiety, deranged sleep, hyperhidrosis, tremor of the fingers or in the entire body, frequent defecation, wasting, fatigue, and muscular weakness. Inspection of this patient immediately reveals the special features in behavior. So they are hyperactive, irritability, fusiness, hasty speech are important symptoms of hyperthyroidism syndrome. Sometimes the patient drops the subject quite unexpectedly and starts discussing another subject. Despite preserved or even increased appetite, the patient may lose much of weight to cachexia. The patient's skin is smooth, warm, and moist to the touch. Some patients develop diffuse pigmentation of the skin, which, however, does not color the mucosa. The pigment is sometimes deposited selectively in the skin of the eyelids. The hair of the head becomes thin and soft, and the characteristic signs are heat intolerance and sweating, subfebrile fever, and tremor. During inspection, special attention should be paid to the size of the thyroid gland and symmetry of its enlargement. If the thyroid gland is enlarged significantly, the patient's breathing becomes stertorous. Inspection of the patient should be followed by palpation of the thyroid gland. So, inspection of the thyroid gland, we have talked about it the previous semester. Revise your knowledge, revise the practical skill, thyroid gland palpation. Ocular signs are noted in patients with hyperthyroidism, include stare, lid lag, lid retraction, and mild degrees of conjunctival injection. These eye signs are largely due to excessive adrenergic stimulation and usually remit with successful treatment. The symptoms of Greffe, Kocher, Stellwagen, Dalrymple, Jelinek, Möbius, and Krause we also discussed the previous semester. Revise your knowledge about these symptoms, symptoms of Graves' ophthalmopathy from the previous semester, and how to check these symptoms, practical skills. This slide presents the enlargement of thyroid gland and some symptoms of Graves' ophthalmopathy. Circulatory system. For patients with Graves' disease, tachycardia is one of the most frequent symptoms. Pulse rate varies within the range of 90 to 120. In grave cases to 150 beats per minute. Systolic and minute volumes, the mass of circulating blood and the rate of blood flow increases. Systolic pressure grows, diastolic pressure falls, and the pulse pressure increases. Auscultation of the heart reveals a snapping first sound and systolic murmur at the apex and over the pulmonary artery, which are due to increased blood flow rate and loud tone of papillary muscles. A most frequent and serious complication of Graves' disease is atrial fibrillation, and the most common is tachysystolic form of atrial fibrillation due to toxic effect of thyroid hormones on the myocardium. Circulatory insufficiency can also develop, and ACG studies reveal slightly increased amplitude of all ACG waves, sinus tachycardia, extrasystoles, and atrial fibrillation. X-ray examination may reveal left ventricle hypertrophy. So the diagnosis of Graves' disease is based on the detailed clinical history and physical examination of the patient, increased plasma levels of triiodtyranine and thyroxine and decreased serum thyroid stimulating hormone, and presence of antibodies against the thyroid stimulating hormone receptors. We also may use ultrasonography with Doppler study of the thyroid gland and detect the enlargement of thyroid gland and increasing of blood flow. So this is ultrasound of normal thyroid gland. This is ultrasound of enlarged thyroid gland with nodules of enlargement of thyroid glands, and this is increased blood flow in case of thyrotoxicosis. The next our topic and the last for today, hypothyroidism or myxedema. Hypothyroidism is the pathological clinical syndrome associated with thyroid hypofunction and characterized by clinical response to thyroid hormone deficiency. Etiology and pathogenesis. Factors causing the onset of primary hypothyroidism are hypoplasia or aplasia of the thyroid gland, iodine deficiency in the body, subtotal thyroidectomy, overdosage of iod, which is given in hyperthyroidism, or overtreatment with propylthyrouracil, metamizole, and some other drugs. Hypersecretion of triiodtyranine and thyroxine upsets normal metabolism and causes changes in tissues, organs, and systems of the body. So there is etiological classification of hypothyroidism. It is divided into primary hypothyroidism due to disorders of thyroid gland. It may be autoimmune hypothyroidism, as example Hashimoto's thyroiditis. It may be iatrogenic, drugs, congestival hypothyroidism, or infiltrative disorders in case of sarcoidosis, amyloidosis, and some other diseases, systemic diseases of connective tissue. The next group, secondary hypothyroidism due to disorders of pituitary gland. The examples may be hypopituitarism in case of tumor, for example, or pituitary surgery and irradiation. Or it may be isolated thyroid stimulating hormone deficiency or inactivity. The next, tertiary hypothyroidism due to disorders of the hypothalamus. So hypothalamic diseases such as tumors or trauma or infiltrative diseases. Clinical picture of hypothyroidism. The symptoms and signs of primary hypothyroidism are generally in striking contrast to those of hyperthyroidism and may be quite subtle and insidious in one set. The main complaints are apathy, lack of interest in the surroundings, difficulty concentrating and poor memory, decreased work capacity, tiredness, weakness, somnolence, feeling cold, weight gain with poor appetite, and impaired hearing. The general inspection of patients with hypotireosis. The patient's appearance is quite specific. The eye slits are narrow and the face is puffy. The edematous neck, skin is pallid with yellowish hue, sometimes with bluish on the cheekbones. The skin is rough to touch, thick, dry, cold and scaly. The skin is thickened due to accumulation in it of mucopolysaccharides, which give the impression of edema. This edema has a special name, myxedema, as a distinct from edema, for example, in case of cardiovascular diseases. Pressure on the skin does not leave depressions. This is a very important idea. Hair on the head is rare. It falls off from the brows. Movements are slow and speech is monotonous, and hoarse voice is typical. Central and peripheral nervous systems. The mentioned complaints are associated with change in the function of the central nervous system. Psychosis may develop in long-standing hypothyroidism. Disorders in the peripheral nervous system are manifested by strong, severe radicular pain in the extremities, paresthesia, cramps, and shaky gait. Delayed tendon reflex relaxation is typical. Cardiovascular system. In case of hypothyrosis, bradycardia develops. The minute blood volume decreases and the blood flow rate is slow. The heart sounds are dull. Fluid containing much protein and mucinous substances is often accumulated in the pericardium. It may be accumulated also in the pleural and abdominal cavity, so patients may have symptoms of hydrothorax, ascites, and hydropericardium. Systolic pressure falls while diastolic pressure remains normal. ECG shows low voltage, especially in P and T waves, but heart failure develops in rare cases. Metabolism. Weight gain is modest and is largely the result of decreased metabolism of food and fluid retention. Protein synthesis is decreased. Blood cholesterol is usually increased. Moderate hypoglycemia is observed. Electrolyte level remains unchanged in most cases. Blood calcium sometimes decreased, and erythrocyte sedimentation rate may be increased. Anemia is often present, usually normocytic, normochromic, but it may be hypochromic owing to menorrhagia, and sometimes macrocytic because of associated pernicious anemia or decreased absorption of folic acid. Reduction of basal metabolism to 50% and also of protein-bound iodine is of great diagnostic significance. Absorption of iodine in the thyroid gland is low. Myxedema, coma is a complication of hypothyroidism. and it may develop in grave cases. Laboratory criteria of diagnosis. Primary hypothyroidism is diagnosed by increased serum thyroid stimulating hormone and decreased plasma levels of triiodtyranine and thyroxine and radioactive iodine uptake, and normal serum thyroid stimulating hormone releasing factor. So these are the symptoms of primary hypothyroidism. Secondary is diagnosed by increased serum thyroid stimulating hormone releasing factor and decreased plasma levels of triiodtyranine and thyroxine, serum thyrotropin releasing hormone, and radioactive iodine uptake. Tertiary hypothyroidism is diagnosed by decreased plasma levels of triiodtyranine and thyroxine, serum thyroid stimulating hormone, serum thyrotropin releasing hormone, and radioactive iodine uptake. So these types of hypothyroidism are detected laboratory. Clinical presentation of all types, primary, secondary, and tertiary, are the same. This is all for